Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 61 of the OBGYN podcast. Today is the Journal Club for July 2019, and joining me today is Dr. Umesh.
Hi, nice to be here again.
Well, it's glad to have you back. It took us about 3 to 4 months to actually record this episode, so we're actually very excited. And the paper we're talking about is Delayed Clamping versus Milking of Umbilical Cord in Preterm Infants, a randomized controlled trial. This is by Samantha K. Shirk et al., and it's from the 2019 May issue of the Gray Journal. So that's how long it's been. I guess it's only 2 or 3 months since we saw it. But we both like this paper. I actually, to spoil a little bit, I think it's actually a pretty good paper, although we do have a couple quibbles, I think. But I think it's an important issue. The introduction of this paper does a very, very good job of going through the history of delayed cord clamping and milking, and I think it actually goes through every single paper that's ever been published on it, which makes it one of the longer introductions that I've read, but it's still pretty good. I don't know, why did you get excited about this, Vi? Why'd you want to do it?
So initially, actually, for one of our resident projects, my first thought was to do a project on umbilical cord clamping in cesarean sections. I was a little bit, maybe a bit off more than I can chew, and was trying to plan an RCT. But I think as part of my reading for that project, I ended up going through a lot of these papers. And I think this topic is interesting because we all talk about it. It's well known amongst OBGYNs, but it's so interesting to me how varied the implementation is, and more importantly, the reasons why people don't implement them. And I think this paper has addressed some of those issues and can make implementation of this a lot easier for a lot of providers.
Yeah, it's a good point. There was actually, in the recent Green Journal, there was an editorial about studies looking at induction methods and how one of the difficulties we've had over the last 30 or 40 years is that everybody uses different protocols with different endpoints. And so even to do a meta-analysis is very difficult on those. Because, for those studies, we really need big numbers. And so either you need a huge multi-center study or you need consistent methods that can then be used in a meta-analysis. And I think we run into a little bit of the same thing here. Right. How long is the delayed cord clamping? Is it 30 seconds? Is it 60 seconds? Is it 2 minutes? Is it milking? How much do you milk? How many times do you milk before you clamp the cord? Exactly. And those all can maybe affect it. Now, to step back a little bit, I guess it was probably about 5 years ago when we really started talking about delayed cord clamping, and that was mostly in term infants who didn't need resuscitation. And they found some good benefits. The longer you delay, the higher the neonatal hematocrit. It also decreases the rate of intraventricular hemorrhage and necrotizing enterocolitis. It also is, on the flip side, associated with higher bilirubin levels and jaundice. But it seems like for healthy babies, that delayed cord clamping is something that should be done for most babies, and that is something that we typically do at Stony Brook most of the time. And then people extrapolated from that, and they said, okay, well, if it's good for term neonates, it's probably good for preterm neonates too, and they have higher rates of IVH and NEC, and so they also have higher rates of anemia, and so probably be good for them as well. But people were basically taking that data from delayed cord clamping and trying to put it onto the preterm neonates. And now, of course, those babies are often NICUs right there. They're ready to take the baby. You don't want to wait 1 minute before you give them the baby.
Exactly. Yep.
So what do you do? And we started doing this at Stony Brook about 4 or 5 years ago. We started milking the cord as opposed to doing delayed cord clamping. And, of course, no one really knew, was it the same? Was it dangerous? We didn't know, but people started doing it. And actually, that's one of the themes I think about modern obstetrics is people see one paper and they just start doing something without necessarily knowing all the facts, and then we put ourselves into a little blind alley. But anything, there's a whole lot of else they have in this introduction, but different papers and meta-analysis. But is there anything else that really stood out that you want to talk about?
No, I think you got most of it. I think, as you said, the term infants is what everyone was familiar with. But I think the fact that the papers that they mentioned also highlight a lot of the preterm neonates that they recommended doing this in. And I think, to me, that was definitely the area that was more interesting because that's where more of the controversy comes up. So I think that motivates the study really, really well.
Yeah, I think if they set up what their question is and why they're doing it. Now, one thing I do want to mention is this is a study done in a developed world. with developed world issues and not an undeveloped world, or not essentially undeveloped, the less developed world. And I think that we keep that in mind, that the benefits of delayed cord clamping with the anemia and stuff, that may be much, much more important in other places than it is here, where we have good, in general, good nutrition, we have good health care, blah, blah, blah. If you're in a place that doesn't have those, you might take that risk of the hypobilirubinemia and jaundice in order to get all those other benefits. Just something to keep in mind.
Right.
All right, so the primary objective of the study was to compare the effect of delayed clamping versus milking of the umbilical cord on the hematocrit concentration in preterm births between 23 and 34 weeks. So that was really just the hematocrit was their primary objective, and then secondary objectives were a composite outcome. Everyone knows how much I love composite outcomes of intraventricular hemorrhage, necrotizing enterocolitis, and the need for transfusion. So that was that. All right, so moving into how they did the study, like I said, they randomized people, mothers who were at risk for preterm birth between 23 and 34 weeks, 34 and 6. It was all done at one institution. They do mention that it is mostly a resident-based, so Medicaid practice.
Yep.
I'm not sure how much that matters, but it is in there. I guess they have different risk factors, which is something to keep in mind. They did exclude people who had Category 3 fetal heart rate tracings, placental abruptions, other reasons for anemia, such as parvovirus infection, although how common was that, I don't know, but it's still a good exclusion criteria. And they also excluded major congenital anomalies, which was just really, again, not all the things necessarily needed to be excluded, but by excluding them, they make their population a little more homogeneous and easier to get a result out of.
And, of course, if the patient's delivered elsewhere, which they had no idea to regulate, that the protocol was followed.
So they did a 1-to-1 block randomization, and there was either delayed umbilical cord clamping for 60 seconds or milking the cord 4 times before clamping, and we will get into that in a minute. Once that people were randomized, they basically had an envelope with the sealed envelope that had their assignment in it, and when they went for the delivery, they would open that and decide which group they were in.
Yep, exactly.
The study was standardized, like I said, about how they actually did the 2 arms, so I'll talk about that for a second. So during a cesarean delivery, the infant was held at the level of the maternal abdomen, and for vaginal deliveries at the perineum, which is kind of standard practice for delayed cord clamping. The delayed clamping protocol consisted of palpation of the neonatal heart rate at the umbilical cord, insertion for 60 seconds. So they are allowing the 60 seconds delayed cord clamping, but they're also evaluating the neonatal heartbeat while they do that. Presumably, if it's very low, then they would stop doing that and give the baby to the NICU team.
I also like that they used the infant warmer as a way to regulate that in terms of timer, because almost every delivery room will have that. So this way it wasn't subjective. It wasn't someone using their phone or a timer. It was kind of a standard way that they would set the 60 seconds. Right.
And it makes sense because the NICU is going to be there for all these, NICU staff's going to be there for all these deliveries because they're all less than 34 weeks. At least that's how it is in our hospital. And they always mark delivery because they want to do the APGARs. They're going to do the 1 minute, 5 minute APGARs. And so they're already timing that. So it just made sense to use what they were already doing. And then for the milking, they stripped approximately 20 centimeters of umbilical cord from the placental end to the infant's end, which makes sense. They did it 4 times, allowing for refill each time before doing it again. And they took that from other studies.
Right.
Then they collected all the data. They did a sample size. And they powered it for a 3% difference in hematocrit between the 2 groups, which is decently small, so it's pretty good. And the sample size determined to be 200, and then to account for 50% dropout, they went to 232.
Which is pretty good, because if you look at they have a nice table where they talk about how many people they ended up getting, and they definitely. They consented 282, of which 204 completed the protocol, so they were close to the range that they were hoping for.
Right. I mean, something they do say is that they had a higher than anticipated number of patients who were excluded, and so they actually kept recruiting past the 232 in order to get to their 200 sample size. And that, when you're doing research design, sometimes you are randomly choosing those numbers to put into your analysis. Like, how much a difference is going to be? Well, you base it on previous literature. Well, sometimes previous literature isn't really applicable to your population, so you end up underestimating or overestimating.
Right.
You estimate a 15% dropout. Okay, well, you haven't done the study before, so you really don't know. So you make a stab at it, and theirs ended up being higher, but they just kept recruiting. So
Right.
that just kind of showed you real research at play there. Really no harm there. And then statistical analysis, this is actually one of the better paragraphs about statistical. I'm not going to read it because it makes it very boring reading. But if you're interested in how to write your paper with your analysis section, this is actually a pretty good one because they really lay out all the different tests they do. They talk about testing for normality. They talk about which tests they use for normal and non-normal populations. So very nicely done. Then they do talk about the fact that they did a intention to treat analysis strategy, which means that whatever group that they were randomized to, no matter what they actually got done during the delivery, they analyzed them as part of that group. They also went back and did do a post hoc analysis, separating them by the actual intervention they received, and they will report both of those. It didn't really end up mattering. All right, so as you said, before we go into results, any concerns about their methods? Anything that you would have liked to see either done differently or any bias you can see that's come out of that?
I think, one of the things that they addressed was the fact that they mentioned the people that ended up getting a different kind of intervention than the one that they were previously expected to get. But the fact that they did that post hoc analysis, I think circumvented that problem. And they showed us that it didn't really matter that even though say a patient was supposed to get delayed cord clamping but ended up getting milking, they accounted for that difference in intervention. And I think some of the stuff you mentioned, the fact that there was a pretty high number of patients that were excluded, and actually many that didn't even meet eligibility. They started with a population of almost 4,000, and they came down to 200. So that seemed like a pretty large drop. But other than that, I don't see any huge issues I had with how they conducted the study.
Okay. There is one thing they're going to bring up at the end, so I guess we can bring it up now, was, they chose a pretty big, broad range of gestational age from 23 to 34 weeks. And there is there are differences there in outcomes. The more premature are more likely to have the necrotizing enterocolitis and the IVH, which are some of the secondary outcomes. And so one thing they did not do is they did not randomize stratify it by gestational age. And they ended up looking at that at the end, and the groups were relatively close, so it probably isn't that big of a deal. But that may be something that they wish they had gone back and done when they were initially setting up the randomization, is to make sure that they would have even gestational age groups.
Definitely. And I mean, in light of that, they also do mention they were underpowered for what you just mentioned, IVH, necrotizing enterocolitis. We've talked about this before just in some of our research projects. The numbers that you need to be able to find differences in those outcomes sometimes can be prohibitively high for a project. So I understand why composite scores are used, but perhaps if they had stratified by gestational age, they could have found differences in those outcomes with a smaller number of patients. So it's interesting. I think that would have been more interesting than reporting the composite score, because everyone reports the composite score.
Well, you do make a good point there, and I think it's one of the issues that we have in OB literature right now is this kind of secondary objective creep, where there are all these secondary objectives which the study is not powered for. And I'm starting to come around to the opinion that if your study is not powered for something, it should not be listed as any objective, whether that be primary or secondary. And I'm not sure exactly how I feel about that yet, but I think that I'm coming around to that. It's not that you can't report those things, and if you do find something that is significant, well, that's great. But to say that there's no difference, you can't really do that if your study is not powered for it.
Right.
And so I don't know, but it's something to keep in mind when you're reading a lot of OB papers these days. Okay, so then we're going to go into our results. As you mentioned, they ended up with 104 in the delayed cord clamping group and 100 in the milking group. And then ones that actually got us, so 78 out of the 104 actually got delayed cord clamping, and 67 out of the milking actually got that. So it's a little bit less in the milking than the delayed. Now, there is... Going back to our power analysis, again, I think there is another issue here is, the study was really powered to have 100 in each group who got the outcome, who actually got the right the intervention, and they don't have that here.
Right.
And so you could argue that their study is really still not powered for what they wanted. So I don't know. I think, how do you do that? You randomize, and I guess once they're randomized and they do the thing, you can actually see if they got it or not. You might actually want to keep enrolling until you had 70, 80 who actually got the outcome, the intervention, or 100 in each group, So,
right, to give yourself a margin, essentially.
Yeah, well, you want to get to that 100 in each group, because that's really what your power said you wanted. And if they didn't get the intervention, then they didn't get the intervention. So anyway, all right. So breaking it down, gestational age, as we mentioned, it was the average was 32. There was no difference between the two groups.
Right.
They didn't find a statistical difference in even breaking it down between 28 and 34 and 9, and 23 and 27 and 9. They were the same. Birth weight was the same across all groups. The arterial pH, APGARs at both 1 and 5 minute were the same. Mode of delivery was the same, although there were a few more operative vaginal deliveries in the milking. It didn't reach significance. There were none in the delayed group. Indication for delivery, again, there was no difference. We're going to see a lot of no difference here. Going into the neonatal outcome in the delayed clamping and milking groups, there was no difference in hemoglobin concentration. There was no difference in hematocrit, although it was a little bit close, with the milking having 51.8 and the delayed having 40.9 with a p-value of 0.07, so that was close. Right. As they like to say, approaching significance.
I know. I found that funny. When most papers say that there's no difference, but there's a trend towards this. I guess in my head, I'm a little bit more black and white with if it's not significant, I tend to not, I don't really care that it's approaching significance. Yeah. But with what you said, perhaps had they reached the 100, maybe that would be an avenue where they would have seen a small difference. Right.
There's a great paper, and I think it was I want to say it was in Nature, but I can't remember. Oh, maybe it was in PLOS. But anyway, they were talking about significance and talking about that, 0.05 or, 0.01 or whatever you want to use. And to keep in mind that it's just arbitrary. Right, we have arbitrarily chosen in most papers, and it's just kind of come, de facto that it's 0.05, but we could have chosen something else. Yeah. Right, and so just because it's 0.07 doesn't mean that it may not be significant. It's just that we have chosen 0.05 as our cutoff. Right, and even at 0.01, there's still a 1% chance that that's a mistake, that it's not actually significant. Right, so. Right. Just something to keep in mind. So 0.07, I usually do get a little annoyed when I see trending towards significance or something like that, but I'm mellowing a little bit on it now because if it is 0.07 or 0.06, I mean, then that's close.
We would have had, yeah.
Right. And so maybe more numbers would have borne that out to actually be significant, or maybe not. Right? It could go either way. The error can go either way on that. Let's see, no difference in peak bilirubin, no difference in the babies that received phototherapy, temperature was the same, transfusion was the same, necrotizing enterocolitis was the same, and let's stop there for a second. So 3 out of the milking group and 6 out of the delayed group. And so again, as we were talking about, in order to really see a difference in those numbers, because there is actually double the number of neck in the delayed group, right, but there aren't enough numbers in the study to make that significant.
Right.
And IVH follows a similar trend. There's 10 in the milking, there's 16 in the delayed. The p-value there is 0.35. Again, with 1,000 people, maybe there would be a difference there.
Right.
No difference in NICU stay, no difference in death before discharge, and then no difference in their quote-unquote composite morbidity. So one of the... I'm going to stop there. So that's basically the findings of the thing. So actually, last part. So then they go into what the actual interventions. Now they're only looking at people who got delayed and people who got the milking. And again, they found no difference. The only thing that was slightly different was in the delayed group. There was 9.1 versus 8.5 for peak bilirubin concentration with a p-value of 0.09. And that was the only thing that was even remotely significant there. Right. Everything else was the same. So... let me go back and ask about this trial here. So they found no difference between the two groups, which is great. What was their purpose here? Why do you think they wanted to do this study?
I think so. This is why this paper was interesting to me, is because I think that milking, in my opinion, is an easier method to implement for several reasons. One is I think that practitioners feel better when they're doing something. I think OBGYNs are notorious for being terrible at waiting, right? So when everyone is just waiting for something to happen, it's not it isn't done as well as if I am physically milking. It makes me feel like I'm performing an intervention. I'm more likely to do that, count, even look at the strip of cord I'm stripping to milk, as opposed to just watching a timer go off from 30 to 60 seconds. So I think the implication for me was similar in this paper, in that they see if you show that milking is equivalent to that of delaying, and more people are likely to be compliant with milking, perhaps that is enough impetus for this to get implemented and us to have the same outcomes for our babies.
Yeah, so I agree with you. And so what I would think about this is that we already know that delayed cord clamping is good, right?
Right.
So we want to know, because milking seems to be easier to do, it's faster.
Right.
And by easier, I mean, it's more, like you said, that we're more likely to actually do it because we're doing something. And it doesn't take a minute. I think they said 6 seconds per milk.
Yep.
So 6 times
seconds.
4, right? So you do that, and then you give the baby to the NICU. So that's a much faster thing. NICU is not standing there waiting for the baby, pressuring you, like all these things. And so as long as milking is not inferior to delayed, then maybe we want to do milking.
Right.
So that got me thinking, why did they do the study this way, and why didn't they do it as a non-inferiority trial?
They may mention that. They actually say, I wonder if they knew that these were the results that they were going to get. Honestly, perhaps they went in thinking that one was going to be superior. But they definitely mentioned on the paper saying one of the limitations was because it was a negative study, so to speak, it should have been done as a non-inferiority trial.
Right. I just, even design-wise, unless they really thought that milking was going to be superior to delayed,
right,
then I would have done it as a non-inferiority. Which is funny. I actually reviewed a paper recently. I don't want to say too much because I don't get in trouble. But they did a non-inferiority, and my big thing was, well, your alternative treatment isn't actually superior in any way. It's not cheaper. It's not easier to use. There's not less side effects. So why are you doing a non-inferiority trial there? Because the only reason to do a non-inferiority is because the alternative treatment is better in some other way, and you want to make sure it's not clinically worse in the thing that you're looking at.
Correct. But with respect to what we just said, even though I believe that milking would have been easier and more people would have gotten on board, they mentioned that their compliance with milking, I think they said 25% of people that were supposed to get clamping didn't, and 33% who were supposed to get milking didn't. Mm-hmm. And they attributed this to practitioner discomfort. Maybe they weren't aware of how to do things. So it wasn't in line with what I thought would happen. I thought more people, I thought the dropout rate essentially for milking would be lower than that of delayed clamping.
True, but you're also, we don't know this institution, but if they've already been doing delayed, you're now fighting against what the normal practices of this hospital.
Right.
And so that can be uncomfortable to people. People hate change.
Right. And actually what I mentioned with you too, I actually don't know how you milk after a vaginal delivery with one hand, unless they're implying, if they want the baby to be at the level of the perineum. So if that's the case, then effectively the person who's delivered the baby is holding the baby there. And then there's this variable segment of cord. So how do you do that with one hand without, causing excessive traction? Yeah. Is someone else holding the baby there when you milk? Right. These are just practical questions that I would have wanted to know the answers to. Well,
they do say this is mostly a resident population, and so presumably there's a resident and an attending there. So if not two residents or a medical student or something. So maybe they can do that. I'll be honest, in my private practice, when I was doing even delayed cord clamping, I didn't hold the baby at the perineum. I put the baby on the mother's abdomen and let it go that way. Either the placenta is still pulsating and pushing blood down the cord, right? Or you're physically milking it towards the baby. Then the 3 or 4 inches in height difference really should make a difference. And in fact, in C-section, where's the baby? On the maternal abdomen. Right. Of course, I guess the physics of that are a little different because the cord's not going to the vagina, but it's still elevated above the placenta, right? So I don't know. I feel like you can probably just put the baby on the abdomen, but that's not how they did the study.
Right.
All right, so let's talk about their strength and limitations. And you read this more recently than I did. So what did they find for their strengths and limitations?
So strengths, this is a randomized control trial, which always adds to the strength of any paper. The fact that they looked primarily at preterm infants, as we talked about, a lot more studies are out there about term infants, but they selected their population to address one that had not been studied as extensively. And from what we understand, they more or less standardized their delivery protocols. They tried their best to have very strict criteria as to how these interventions would be performed. So even if practically, say you put the baby on the maternal abdomen, I think all the people who underwent the intervention did it all the same way. And that always is important when you compare outcomes. In terms of limitations, I think one we briefly touched on, given it's a negative study, considering non-inferiority design would have been helpful. They also talk about how the study was really powered to evaluate the difference in hematocrit, which is effectively a surrogate for the need for transfusion, but it was underpowered for some of the other more interesting outcomes, mainly because of the clinical significance. Necrotizing enterocolitis, IVH, neonatal death, these, although rare, have much more serious implications and are a clinical significance compared to necessarily the difference in hematocrit. And honestly, we touched on all this already. A lot of it is stratifying, focusing more on the less than 28 weeks gestation, because there's a very low number of participants in this group. I think they mentioned 14.2%, which is low given the overall number of people in the study.
Okay. I mean, you're right. We basically went through all that already. It helps. It's a pretty straightforward paper. One thing I'll say about the non-inferiority trial is that typically with a non-inferiority, your numbers are actually smaller. So your power analysis, well, you'll have a smaller number of women to include or babies to include. And so actually, if it had been designed that way, they actually might have been powered sufficiently to show that there was no difference between the two of them.
Right.
So that's one thing. We could actually probably do that power analysis for them and see. Kind of illegal to do it afterwards, but we could do that. And then I think you're right. I think that the same study could be done between 24 and 28 weeks. Maybe you need the same numbers, need 100 in each group, and then maybe you will see some of those differences in NEC and IVH.
And one more, I think I want to add strength that I thought was the fact that they did that ad hoc analysis, like we talked about, and they noted similar outcomes when the data was evaluated by the actual intervention rather than the intention to treat, which I think helped them account for some of the lack of compliance in either treatment group.
Right. And we didn't say this, but when they did that ad hoc at the end, there were 112 who got delayed and 73 who got milking. So you can see that there were some in each group that got the opposite treatment than they were supposed to. But we look at 112 and 73, it's a little bit better than just looking at the
78 and 67, yeah.
Right. So, all right. So, I mean, I guess the questions I always ask myself at the end of a journal article is, one, do you believe the result? So we'll start with that. What do you think?
I think I do. I mean, they didn't report anything that I haven't already sort of come across in some of the reading that I've done. So I'm more inclined to believe this result because I've seen it consistently.
That's good. So you got some confirmation bias there.
Exactly. And I mean, as I said, clinically, it makes sense to me. I think what they're showing, I do agree with you that perhaps this study would be more interesting if they were to increase the number of participants, and maybe that would increase the relevance of the study. But for what they set out to do, comparing the two and telling me they're both equivalent, I, as a provider, am probably more likely going to milk than delay. And if that is going to confer the same benefit, milking is better than nothing. So therefore, I'd probably do that. So it changed my view on what I would do.
Okay, so that's pretty good. I agree with you. I think I believe the result, and you're right. I mean, it goes along with what I expect the outcome to be, which I always worry about because, like I said, there is confirmation bias there when something tells me something that I already believe, so right. I'm likely to believe it. And then next is, do you think that their population is our population?
They talk about, so I guess I'm not really sure what the population in Cincinnati, Ohio is, but the fact that they talk about it being primarily a resident population is already somewhat analogous to the population that we see. Mm-hmm. So I'm inclined to believe that is the biggest commonality between the two.
Okay. I mean, we'd have to go back and look at what our preterm delivery patients are and what their demographics are, but in their group they were 37% black, 57% white, a little bit Hispanic, some unknown, and there was 0.5% Asian, right? Ours is more heavily skewed towards Hispanic than black, but overall relatively similar. The maternal age was there were 16% that were advanced maternal age, 10% had diabetes, 13% chronic hypertension, 32% had preeclampsia. So, I mean, again, I'd have to go back and look and see. I know what our population is like for total. This is a very specified subgroup here, and the preeclampsia rate and the diabetes rate and all that stuff's probably going to be higher in that group anyway, but nothing's crazy there. And even their overall rate, so they had 4,200, 4,300 almost women who delivered during that time period, and 300 and something, 310 who were preterm. So really it's a 8% preterm delivery rate, which is about in line with what we have.
Right. The other interesting thing, and I guess I don't know if this matters as much, but I always wonder when people are doing the protocol, what percentage, say, of the attendings were MFM providers versus generalists? Were the MFM providers more or less likely to engage in this trial, or were they more likely to do one intervention versus the other because of their inherent biases compared to generalists? This is something that I've always been curious about when we do these kinds of analyses, because I think there is a difference in how things are implemented based on one's level of training. Fair
enough. That's an interesting point, and I can see the kernel of a research idea in there coming. We'll have to talk about that offline. And so the last question is, and you kind of already answered it, but are you going to implement this in your own practice?
I think so, especially during C-sections. I feel like that is where, in my limited clinical experience, I have seen us in the midst of delivery just not forget to delay, and delaying in a surgery when everyone is just watching the hysterotomy bleed, even if people have shown that there's no difference in maternal blood loss without waiting, is a lot harder for people to do. And I think milking is quick. It's total of 6 seconds. It can be done just before we clamp the cord. And I think I'm going to try it for the next 5 weeks that I'm on OB and see how easy it is to implement and how easy it is to get other providers on board to do it.
So the next question is, do you think we should make this a protocol for our institution?
Well, I'm biased because I love protocols and I love implementing new protocols. But I think that it would be worthwhile. I feel like I want to say the bridge is that we, at Stony Brook, do a lot of evidence-based discussion of guidelines. We do great journal clubs. We talk about these things frequently at Sign Out. But there is a gap between that discussion and how it's actually implemented. And I've noticed this with even some of our projects that we do as residents. If we find statistically significant findings, the implementation is where there's a gap. And some of it is, of course, lack of education, lack of protocols. So I believe if we're putting in the time to review the research and people are putting in the time to do the research, why not implement it? And yeah.
All right, let's do it then.
Okay.
All right. So we'll report back on that sometime in the fall about how we're doing on getting everyone to milk the cord 4 times in preterm deliveries. All right. So yeah, overall, I think this was a very good paper. It was very well written. I like the design of it. I didn't really have too many issues. Again, there are issues in retrospect that we can bring up. But sometimes you don't know those issues until you've done the study. And they do a very good job of articulating those issues that came up either while they were doing the study or afterwards. So I can't fault them for that. All right. Any final thoughts on the paper?
No, I think this was a great study. I'm glad we finally got a chance to talk about it. And as I said, I hope something changes in our practice at Stony Brook, which would make it even more exciting to have reviewed this.
Absolutely. If any of you listeners out there, if you have experience with doing this at your hospital or doing these protocols and something you want to talk about or you want to send us some feedback, remember you can send everything to feedback@obgyn.fm. I'd love to hear from you all. If you have any either ideas for future episodes, then please let us know. I think finally, maybe next week, I will put out the first episode of my diabetes and pregnancy. I know it's been like 6 months I've been saying that, but I think I'm finally going to do it. And until then, I want to thank Dr. Umesh for coming on and talking about the paper with me.
Absolutely. Always happy to be here.
And thank you all for listening, and we'll see you back next time.